Okay, hi everyone. Welcome. We're excited to see a lot of people joining still. If you'd like to put your name and your organization in the chat, we'd love to find out who's here and let you all see each other. We're going to get started in just a minute. Hi, Jay from Mammoth. Thanks for chatting. Casey, Amanda. I love seeing people chat their names in. Kate, Caroline, Wendy. Oh my God, this is great. Okay, let's go ahead and get started. Welcome everyone. My name is Serena Clayton. I am the Executive Director here at California Bridge. And I'm really excited that you are all taking your lunch hour to join us for our webinar, Treatment, Not Criminalization, Why Clinicians Should Care About Drug Policy. So I think that most of you know California Bridge for the tools and resources that we provide on medication for addiction treatment and substance use navigation. And in fact, one of our goals is that our model for treating opioid use disorder will be the standard of care in all California hospital emergency departments by 2023. So just a side note, we're about a third of the way there. But of course, our real goal is not about like a particular model of care, but it's really about advancing the health and well-being of people who use drugs. And so when we step back and we look at what it takes to achieve that goal, we're confronted by this one undeniable reality that kind of takes us a little bit out of the comfort zone that most of us probably work in. And that's the fact that people with substance use disorder, the patients that many of us are involved in treating on a day-to-day basis, are considered criminals under the current law. So their medical condition is a condition that they can go to jail for. And this is relevant to our goals as health professionals because going to jail and having a criminal record does not promote health and well-being. It's not a therapeutic intervention. And having the threat of incarceration does not encourage anyone to come forward and seek help. And of course, that's particularly true in communities of color where there's been a disproportionate level of incarceration for drug use. So at California Bridge, we decided that we weren't going to sit on the sidelines of this issue. And we decided to take a public position in support of decriminalization of personal use of drugs. So just to be clear, this doesn't mean that we're supporting legalization or the legal selling of drugs, but just that people should not go to jail simply for using drugs themselves. So our goal for today's webinar is to get more people in the health field to learn about decriminalization, to recognize it as a health issue, and to get involved because there's a really important role that we can all play in this issue. So today we're first going to hear from Charles Hawthorne with the National Harm Reduction Coalition, who's going to talk about how the war on drugs got us to where we are today. And then we're going to hear from Teshia Naidu with the Drug Policy Alliance, who will talk about specific policy efforts around the country and specifically here in California as well. So if you have questions during the presentations, please type them into the chat and we will address as many as we can after the two presenters. And then in closing, we're going to have some words and next steps from Dr. Amy Mullen, who's with UC Davis Medical Center, and she's one of our founding directors of California Bridge. So then lastly, before we get started, I do want to clarify that our work on drug policy here at California Bridge is not supported financially by the state of California or by any of our other foundation grants. So let's transition over to Charles, and I will introduce him as he gets his slides up. Charles is the Capacity Building Manager for the National Harm Reduction Coalition, and we've been really fortunate to work with Charles and his team. They've led several trainings for our clinical team and our substance use navigators, and they always get rave reviews. And another thing that's really inspiring about Charles is that they're currently pursuing their master's in public health from Johns Hopkins University as a Bloomberg American Health Initiative Fellow. So I'm super excited to turn it over to you, Charles, and thanks for being here with us.
Hey, awesome. Thank you so much, Serena. All right, so hello, everyone. Thank you so much for so many people being on here. We have 100 people on this call right now, and I'm really excited to talk to you all about just a brief history of U.S. drug policy. And what I hope to do during just my little piece is to put into context the root of U.S. drug policies, what it actually serves to do, and actually kind of start pushing you to kind of challenge yourself to think about what do you see your role being in dismantling these policies as it relates to improving the health of our country and of people who live here. So just to start out, something that I always like to have people consider in my trainings is, what was your first drug education experience? And you're welcome to go ahead and type this into the chat if you feel like you have a really good answer. But I've heard a few different ones throughout my time, including people being in like the DARE program, people getting some sort of education. Oh, the Nancy Reagan campaign. Okay, Brian, I see that. Just say no. The eggs frying in the pan. We've seen that before. Like you drop the egg in the pan, like this is your brain on drugs. Zero tolerance policies, absolutely. And something that we're all seeing in common throughout these threads are abstinence-based only education, not even once. So conversations around, even if you use this drug one time, that's already too much. Police presenting in science class, PCP causes you to become violent. So this attachment of substances to violence, to harm, all that stigmatization that is happening. And so what often happens during these drug education experiences is there's very little focus on what does your health look like as it relates to drug in a more conversational way, more along a spectrum. And instead it kind of focuses on one end of like addiction, of like whenever you talk about drugs, it always goes to addiction. And therefore the only way to navigate substance use is through abstinence. But the reality is this is a very new perspective, because drugs have been around for way longer than these ideas have existed. There's actually there's a word that I read in a really great book called Straight by Hannah Blank, which is a book about the history of heterosexuality. And in this book, she uses this word called doxa. And doxa is a word, it's a Greek word that means something that we've always known. And so something that we have always known is that drugs are bad, is that drugs cause harm, is that they are illegal. But the truth is, this has not always been the case. So even going back to earliest periods that we can kind of recognize human history, there has been evidence of substance use dating back thousands of years. So going back to like 10,000 years ago, where they're finding remains of alcohol, finding remains of hallucinogens in places where people were storing them and keeping them, finding remains of opiates and coca in the bones and plaque and tissue and remains of bodies in Italy and in Peru. There's also lots of evidence that animals have used like rotting fruit and psychoactive plants as a way of getting similar, very similar highs that humans seek as well. And so there's always really been a relationship between humans and plants. And psychoactive plants were actually some of the first plants that humans cultivated and grew for their own pleasure as part of the beginning of agriculture. And then, so we can start talking about 10,000 years ago, but even up into the late 1800s, a lot of drugs were still very widely available. And so drugs like cocaine were available inside of tooth drops. So if you've ever seen in like a movie or something where somebody will use cocaine and then rub it on their gums, that is something that numbs your gums. And so people were using cocaine as a way to numb your gums. And when you're navigating tooth pain, that's really effective. Or Bayer, the original like aspirin company, selling like aspirin and heroin as a pain relief medication. And heroin is a pretty effective painkiller, and people were using it for this purpose. And these were just available in pharmacies. These weren't really a really high barrier to get. These were just something that you purchased over the counter with your local pharmacist. And then something changed. Something shifted that kind of started this domino effect of the way criminalization happened. And what had happened, it happened actually right where I'm at. I'm in Bay Area. So the first ever local drug law in the US was passed in San Francisco in 1875. And if you know anything about kind of California and West Coast history, especially, that is during the time that Chinese immigrants were coming into the US, specifically to work on railroads, to do manual labor. And they were and when Chinese immigrants came in, something that they brought with them was the practice of smoking opium. And when they brought this practice over, a lot of people who were here, specifically white people who did not like what was happening, especially around young Chinese men who were coming into the US to work, who did not have families or kids. They were just kind of had their money and they were having fun with it. And they did not see that as a good thing, especially when it came to having with opium dens, which is a pretty stigmatizing term, that white women were hanging out with Chinese men, that were fraternizing together, that were having sex together. That was a problem. And so in 1875, the first local drug law was passed in San Francisco, and this outlawed the smoking of opium. No, this did not outlaw the eating of it, the taking of it transdermally, this did not outlaw injecting, only this one form of use for opium, which is something that we've seen that comes up again when we start talking about crack, around how crack is more heavily criminalized than cocaine, even though crack is just a smokable version of cocaine. And so when this is kind of the first example of racialized drug laws being passed as a way to control people in a situation. And then things kind of continued along that path. So during the same time, heroin and cocaine were starting to become associated specifically with Black Americans, specifically as it related to Black Americans being released from slavery and able to have more agency over the work that they did, having to be paid to do that work, and often working harder and working longer hours than white people whose jobs they were, especially like working class white people whose jobs they were now competing with. And people did not like that. They said, like, we don't understand, they are working all these hours, they're putting us out of business, and that's a problem for us. And so this Harrison Narcotics Tax Act was passed. And this tax act, even though it didn't like outlaw drugs outright, what it did do is it placed a really high tax on getting them and kind of put the burden of this tax onto pharmacists and doctors. And so effectively, nobody could really access this. And so it was effectively outlawed. And at the same time, so you have kind of this opium situation happening with Chinese immigrants out West. We're having all throughout the country this opium and cocaine and heroin being specifically related to Black Americans and people having having issues with that and wanting to outlaw cocaine and heroin because of that. And then at the same time, we're having marijuana prohibition start in the southwest part of the country. And in some ways, you might talk about how there were Mexican immigrants who were coming into the US. Also, what happened was the border crossed a lot of people who were in Mexico, and then the border moved, and now they're in the US. And there's a lot of racism and xenophobia coming out in those moments. And so in the same way that these kind of previous racialized drug laws came into effect, marijuana started to kind of have the same path. And specifically, there's this man named Harry Anslinger, who was kind of the chief person in the anti-marijuana boat. And Harry Anslinger became the first drug czar of the US. And so that would basically be like the person who's in charge of the DEA. And Harry Anslinger has some choice quotes about cannabis that I'll share from the 1930s, including "Reefer makes darkies think they're as good as white men," and referring to the people who smoke marijuana, saying most are Negroes, Hispanics, Filipinos, and entertainers. Their satanic music, jazz, and swing result from marijuana use. This marijuana causes white women to seek sexual relations with Negroes, entertainers, and any others. So we're seeing this same path kind of come out for all of these different substances at different points. And these are all kind of the same story that's happening. And also, Harry Anslinger is a smart man who wants job security, and he recognizes that just outlawing marijuana or just outlawing cocaine or just outlawing heroin isn't really enough to justify a department or a job. And so what his campaign throughout his career becomes is just outlawing pretty much all drugs that were anywhere near illicit at this point, or funneling them through more of an FDA capacity. And so Harry Anslinger was the first person who was really pushing for this. But he was not the last, nowhere near the last. And this wasn't even really before the war on drugs actually kicked off. And that didn't happen until Richard Nixon in 1971. So actually, if you check your calendar, this June will be the 50th anniversary of the war on drugs, of Richard Nixon declaring the war on drugs. And in this, he said, to wage an effective war against heroin addiction, we must have international cooperation. In order to secure such cooperation, I'm initiating a worldwide escalation in our programs for the control of narcotics traffic. And I'm proposing a number of new steps for this purpose. So we're seeing at this point, what's happening is Richard Nixon is scaling up our internal, our national policies around substance use and around drug prohibition, and also scaling them up across the world. So the US exported our drug policies across the world to all different corners, and really pushed for both the prohibition of substances, as well as caused a lot of damage in trying to destroy supply side issues as well. And what we really learned from this situation is, like, why are some drugs illegal and others are not? And that's kind of the question that we sit with. And I also want to really drive this home for a lot of the folks on the call who do have prescribing power, who prescribe medications and administer medications, really thinking about that. Because what we do know is a lot of the substances that are illegal substances are very structurally similar and have very similar effects to substances that are available, that are not available with a prescription. And so we see that all the time in the difference between Adderall versus methamphetamine, where the only real difference between those medications is a carbon instead of a hydrogen on the chemical structure. And really what we've seen over and over again, that what makes a drug illegal has a lot more to do with the people who are using it and what those people are associated with than anything else. And this was not made any more abundantly clear than in a quote from John Ehrlichman. John Ehrlichman was the assistant to President Nixon for his domestic affairs, so inside of the country. And he did an interview that basically talked about this. And this interview came out years later, well after his tenure had ended. And actually, he did his interview after his tenure ended, and the interview did not get released until after he had passed away. But what he said in this interview was, we knew we couldn't make it illegal to be either against the war or black. So at this point, we're talking about the World War II that Nixon is engaging in. But by getting the public to associate the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt those communities, we could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So when we are really starting to put into context all of these policies, they have not much to do with health. They don't have really anything to do with protecting people. What they have everything to do is politics and racism and control and power. And that's what we're really trying to hold as we move into providing care for people. And in previous times, this is not a way that we framed substance use. This is not a way that we framed addiction. And even more than this is not the first time that these policies existed. They were not only created in the US. There's a long history along with substance use of different ways that people try to control and regulate and prohibit substance use. But overall, what we know is the way that these policies are built, specifically in the US, are not based on health, and they are not based on providing people the best possible care. And so where I kind of want to leave you is thinking about, how do these policies impact medical providers? Often what they do is they create a barrier. They make it hard for providers to engage with their clients in a way that is kind and stigma-free and allows clients to be open and honest and transparent about their substance use because of fear of stigma, because of fear of having their care taken away. These policies make it really hard for providers to actually meet people's needs, because we know that when people are so busy when, like Serena said in her opening, where it's like sending people to jail does not make them healthier. And when sending people to jail as a response to a medical issue or even an issue of choice, it puts people in a place where their health is worse, where they're not able to deal with other health issues as they come their way because of what happens when you are criminalized in this country, including having access to welfare services, access to education, all those things taken away from you. And so it's important to hold that it is in medical, if as a medical provider, your goal is to help every person access medical care and to be healthy and to have a high level of health and well-being, then these policies are a key part of what we need to dismantle in order to get there. All right, that's all I have. I'm going to go ahead and turn it back over.
Great. Thank you, Charles. We always love hearing from you. We hope we're going to hear from you again in the future. So while Teshia is bringing up her slides, I'm going to just give a brief introduction. Teshia is the Managing Director for Legal Affairs at the Drug Policy Alliance, and she's been with DPA for over 15 years. She's worked on multiple policy reforms in multiple states, including the ballot initiative that recently passed in Oakland, which she's going to be talking about today. Drug Policy Alliance is the leading national organization working to change drug laws. And while we at California Bridge haven't necessarily taken a position on all of the issues that DPA works on, we're really looking forward to working with them to bring our expertise in the treatment of substance use disorder. And I use that term to apply to all of us here, everyone on this webinar. We want to bring that expertise to inform the work that they're doing on decriminalization, which is what Teshia is going to be talking about today. So Teshia, it looks like your slides are ready. Go ahead.
Thank you so much, Serena, and thank you to California Bridge for hosting this really timely conversation. I'm really excited to be a part of this panel. So before I jump into my PowerPoint, I'd like to give you a roadmap for what I'm going to cover. First, I'm going to talk about what are some of the real world implications of the decision to use our criminal justice system as a response to drug use. And I'm sure we all can agree that drug use is fundamentally a health issue. So I'm going to try and draw out what some of those consequences are. And then next, I'll turn to Oregon. And I know in Serena's introduction, she mentioned a ballot measure in Oakland. It's actually in Oregon. So I'll talk a little bit about the first policy in the United States that dares to be different and incorporate an alternative approach from criminalization as a way to address drug use. And then finally, I will conclude with what's next with a focus on California, and then also an appeal to all of you, health and public health practitioners, to with some suggestions for how you might get involved in drug policy. As Serena mentioned,
Teshia,
yes?
can I interrupt you for a sec? Can you put your screen in full screen so it's bigger?
How about that? Does that work?
Yeah, that's great.
Perfect. Thanks for letting me know, Serena. And then one other thing is, Serena, in Serena's introductory comment, she talked about decriminalization. And I just want to kind of re-emphasize the point that Serena made, that decriminalization is fundamentally different from legalization. Decriminalization is really the elimination of criminal penalties or using our system of arrest, prosecution, and incarceration as a response to drug use and drug addiction. Legalization is something separate, which essentially allows for legal access to substances, and usually it's a regulated market where substances can be sold. As I'm sure a lot of you are aware, there's marijuana legalization that has spread across the country. Decriminalization is something completely separate, which is really just taking drug use out of the criminal justice system. So that's some initial framing, and happy to tease out more during the Q&A section. So starting with some of the harms of criminalization, my previous speakers have touched upon this, but I just want to add some finer points to this. Drug possession is the single most arrested offense in the United States. What that means is more people are arrested for the possession of drugs for personal use than any other offense. That translates to 1 arrest every 23 seconds. Charles set up this point very well in terms of racial disparities. There are racial disparities in the decision to stop, arrest, prosecute, and incarcerate someone for a long period of time. And a lot of these disparities are really based on unequal drug enforcement practices. The consequences of an arrest are severe and don't just involve a loss of liberty at the time of an arrest, but really have their lifelong consequences associated with an arrest and could lead to impacts on employment opportunities, family obligations, housing, and puts up barriers to physical well-being. A conviction for a drug offense can essentially follow someone for the rest of their lives. And if you are an immigrant, you could be ripped apart from your family and deported to a country that you might have no connection with. We all know, and every day if you open up a paper, you see these skyrocketing overdose rates. And despite our concerted effort in this country to address issues of drug use, we see that overdose rates are at an all-time high. And as a result of the decision to invest in our criminal justice system to address drug use, what that has meant is that we've had a lack of meaningful investment in the treatment and harm reduction infrastructure. So we've prioritized funding police, prisons, court system over our system of public health, which I'm sure we can all agree is more adequately suited to addressing any kind of issues with drug use and problematic drug use. So some of the benefits of ending criminalization, which it's basically the mirror opposite of what I just, or the opposite of the problems that I just highlighted. Reducing the number of people caught up in the system, that's kind of an obvious one. And then the racial disparities go together with that, reducing some of the racial disparities in enforcement practices. Importantly for this community, I want to highlight that somebody without stigma and the fear of arrest, people are more empowered to seek treatment. And the decision to criminalize is essentially a barrier to accessing treatment. And one major example is in the context of pregnant people who use drugs. There are states that actually criminalize women who use substances during pregnancy under their child abuse statutes or under neglect statutes. And what we've seen from those states is that it really poses a huge deterrent for women to seek treatment and prenatal care, which as practitioners, you all are aware that one of the key indicators of successful pregnancy outcomes is prenatal care. And so by criminalizing drug use during pregnancy, we've seen that it's actually been a barrier for access to vital services, including prenatal care and drug treatment. Decriminalization also improves treatment outcomes, drawing from international models, Portugal being one of the key initial adopters of a decriminalization model. We've seen that treatment outcomes have vastly improved for people who are using drugs problematically in that country. And then criminalization or removing it removes barriers to evidence-based practices. For example, drug checking to check for adulteration of a substance. When those kinds of practices or equipment is considered paraphernalia, where somebody could be arrested for possessing that equipment, it essentially puts up a roadblock to adopting evidence-based practices that might have an impact on preventing overdoses, for example. So turning to, a fundamental policy shift in the state of Oregon. I mean, ever since President Obama and, in recent years, we've been hearing people say, we need to treat drug use as a health issue. And we've seen a lot of lip service to treating drug use as a health issue, but it has always been through the lens of the criminal justice system. So when people mention treating drug use as a health issue, they really meant drug courts. So once somebody's arrested, they might get into a drug court program heavily overseen by a judge who makes decisions about treatment and programming for an individual. And then failing to participate in some of, or failing to meet some of those conditions could lead to somebody being kicked out of the system. That's what people considered a health approach or a health approach to drug use. But the reality is that we can never truly have a health approach if we have our system of punishment and criminalization that is the very entry point for somebody to access treatment and services. Decriminalization is not condoning drug use, but it's simply saying that there are other more effective systems in place that should be addressing drug use and drug addiction and problematic drug use. So learning the lessons from a number of other countries, including Portugal, we worked on a ballot measure in the state of Oregon that passed in November, this past November, that essentially decriminalized possession of drugs for personal use and at the same time vastly expanded access to services that are needed for people who might who use drugs and might need some services. So for example, what the measure does is it vastly expands funding for treatment and the public health infrastructure. So one component is it funds addiction recovery services where they could be triaging of the acute needs of the individual and connects them to intensive case management and services. The second component in Oregon, where it decriminalized, it also expanded the community's access to care. And the way it did that was by creating a single point of entry, a screening line where somebody could contact this screening line 24/7 and get connected to a host of services, including treatment, housing, which is a critical shortage in Oregon and certainly in California and elsewhere, harm reduction services, as well as peer support and recovery support. So the Oregon, it just passed, the measure just passed a few months ago, and it's being implemented right now. And so we'll wait to, it's going to be vigorously evaluated. There is an evaluation component to this program. But Oregon is really the first time that we have a policy at the statewide level that dares to be different, as I mentioned at the beginning, tries to truly figure out a way to have our health and public health system be the first responders rather than what has been currently the situation with the criminal justice system. So I want to highlight real quick that even though Oregon is, if you look at any kind of news stories about it, it talks about Oregon's decriminalization policy. But when you just dig and scratch beneath the surface of the Oregon policy, you realize that it's truly one that places treat health first. It centers health and individual dignity over punishment. And as a result of what the measure's goals were, we've seen tremendous support from the health community. And on the slide, you can see who some of the key supporters during the campaign. These were very vocal supporters of decriminalization, because all of these practitioners, what they could see is that the current system was incredibly harmful for their patients and for the people that they serve. So what's next? Oregon was adopted as our system of government. The states are laboratories for experimentation. So Oregon has its model. But we're really at this point trying to identify how can we get such a model or something similar to an Oregon approach adopted in other parts of the US. And so looking at California specifically, what we're trying to do right now is figure out, is there a way to build out the alternatives to incarceration? Can we create a 24-hour screening line where somebody contacts the line similar to a suicide prevention line, and you call that number and the individual could get connected to services that way? There are county-specific, screening lines and assessment lines that might be available, but it's for a very targeted population. So we're trying to figure out, can we use the budget advocacy at the state capitol to try and expand something like that, a screening line throughout the state. That's going to probably be a multi-year effort, but we're currently working in various coalitions to try and figure out how to do something like that. We're also trying to evaluate what is the treatment and harm reduction services infrastructure in the state. What are the gaps? And not just in terms of the types of services, but also in terms of geographic gaps. What are the barriers to access to services in some communities? Should there be mobile units? In the context of COVID-19, there's been some innovation in terms of telehealth. So how can we expand services to individuals in far-reaching places? And then finally, we're trying to identify some revenue sources to fund the expansion of services. I'm happy to explain how we did that in Oregon, but California is a different place, and so we were trying to figure out how can we identify how to fund various services that might be needed. So finally, I just want to conclude with the critical role that members of the health and public health community plays in drug policy. In doing public polling and opinion testing for quite a few years now, one of the most respected voices when it comes to drug use is the people on this in this webinar. It's the health community and public health community. Medical professionals are trusted sources of information, and just want to highlight that when Portugal decriminalized drug use and drug possession in the early 2000s, the whole policy started with a doctor. It was a doctor who saw his patients cycle in and out of the system and said, we really need to do something different. And now we have a model that's been studied and is being replicated in a number of countries around the world. So there's a really important role for the medical community, the health community, public health field to get very actively involved in drug policy. It's important to educate your friends and colleagues. I mean, you are trusted. You're a trusted source of information. share this information with legislators and other decision makers. Your frontline experience is critically important, and you have a lot of legitimacy with decision makers. So use your privileged position in society to try and educate decision makers. To the extent that we're going to work on a ballot measure in California or even legislative approaches, would absolutely value your input because you know where the kinks are in the system, where are the bottlenecks, what are obstacles that need to be overcome. You're at the front line, so provide some input about how the system could be improved. And then finally, join the coalition. California Bridge has a great statement endorsing decriminalization. Join the coalition and be an ambassador for promoting alternatives to criminalization, for really centering health and well-being in drug policy rather than criminalization. So I will stop there and thank you so much for your time and attention.
Great. Thank you, Teshia. Thank you so much. And also thank you, Charles. So I'm going to ask the first question, and then I have a couple of you have typed questions into the Q&A, which I see, but other people, please type them into the chat because we're not actually actively monitoring the Q&A, but I will ask these questions. Teshia, I want to just raise an issue that I think we hear about a lot. And I just want to hear, and Charles as well, your response to this. So one of the concerns often with decriminalization is, well, two really, is increased use of drugs. It's not going to be illegal. People are going to, have free access to drugs. It's going to make the problem worse. And then the second is this idea that you will lose, like if you think about, I don't know if this is the right, if you think about carrots and sticks, like having that threat of criminalization actually gets some people into treatment, and that's a good thing. And if we don't have that, people won't go into treatment. So I'd just like to hear your response to those two issues that I hear a lot.
Sure. So I'll kick it off, and I'm sure Charles will have a bunch to add. Starting with the question about drug use rates increasing as a result of decriminalization. I'll start off by saying, you can look at information from the World Health Organization that has found that how punitive a policy is has no impact on drug use rates. So that's one thing, and I'll try and find the report and put it in the chat if I can during the webinar. Secondly, in looking at Portugal, who decriminalized in 2001, so we have about 20 years of research from Portugal, and drug use rates in that country did not increase significantly as a result of decriminalization. If anything, what happened is problematic drug use decreased, and the way it's defined is intravenous, so injecting drug use decreased, and youth drug use decreased after decriminalization got adopted in that country. The reason why is that decriminalization is not just about eliminating criminal penalties, it's also about expanding the systems that have been neglected as a response to drug use. And so what we saw in Portugal, there were all of these positive health indicators as a result of decriminalization because of the expansion in the health and treatment system. And so HIV rates decreased as a result of decriminalization because they expanded harm reduction interventions like, access to clean needles. They were positive treatment outcomes because people said we feel more empowered to seek treatment because now we're not stigmatized through the criminal justice system. So the data doesn't really support the view that criminal penalties or criminalization impacts drug use rates. Those rates rise and fall regardless of how punitive a policy is. And when you look at the United States, where we have incredibly punitive policies when it comes to drug possession and a whole host of drug-related conduct, the US has among the highest rates of drug use in the world. So, so the evidence is not there for now the drug use rates are going to skyrocket. So I can address the second question, but I'll let Charles, see if Charles has anything to add.
I think you hit the nail on the head, Teshia. I think the only thing I would add is just, I totally agree. When we look at the US, it's like we've been criminalizing drugs for a long time, 50 years, 60 years, 100 years at this point. It has not gone down, it has only gone up. Because what we know is the things that drive up drug use are not legalizing it. The things that drive up drug use are poverty, houselessness, poor access to medical care, stigma, racism, transphobia, misogyny. Those are the things that push people to use drugs, not how legal or illegal it is. And so that's what we actually want, we should be working on. If our goal was to stop drug use, those are the things we would be putting our work towards. But that's not the goal of the war on drugs. The goal of the war on drugs is to criminalize people and to act as feeder for our prison industrial complex, in which so much of our economy of the US is based on people being in prison. And then on top of that, right now, our drug treatment rates are abysmal. They're not good. The fact that like so many people go to drug treatment and so many people are not successful in drug treatment is an indictment of our treatment services. It's not a good thing. I think a lot of the times people look at that and they say like, well, that's just what happens. People aren't ready. And it's like, so why are we putting people through who aren't ready? If all we're doing is traumatizing them, if all we're doing is harming them, and ultimately all we're doing is really putting them at a higher risk for an overdose when they come out of that, because this is borderlining on malpractice, if we're being honest. And so really, I really want to push people to think outside of a dichotomy of how much or how little we criminalize something, because that shouldn't be what we're talking about. We shouldn't be criminalizing people. And what we should be talking about is how much we are actually creating opportunities for people to be safer, for people to not need drugs to live their life. And how are we actually creating a space that people can seek treatment willingly if that's something they're looking for.
So we're getting a couple of great questions, and I want to ask a question that Tommy raised about crime. So do either of you know anything about in Portugal and in other places where they've decriminalized, has it had an effect on crime rates one way or another?
So I'll just say briefly that what has been studied is like drug tourism, for example. Has that gone up when Portugal decriminalized? And even studies by the United Nations have found that no, drug tourism was not an issue. We didn't see all of a sudden a number of people rushing to Portugal because of decriminalization. In terms of some of the other crime rates, I don't have that data available. But what I will say is that after decriminalization, it really did free up law enforcement resources to go after offenses that might pose a threat to public safety. And so by freeing up those resources, I don't know what the impact has been specifically because I can't talk to the data, but what we have seen is that there were increased convictions when it came to trafficking offenses and distribution offenses in Portugal after decriminalization. But I don't know about property crime rates or anything like that.
And I just add from a data analysis perspective, crime is a really hard metric to work with because does crime go down because we're arresting less people for drug use, or as Teshia was saying, is crime rates going up because police are focusing on other things? Is that a good thing? I don't know. Those questions are really complicated, especially when we're working within a reality where, especially in the US, where our executive branch and our police are not tied to actually do things that are about improving public health and improving public safety, but they are instead in a state of following orders that are passed down to them that are often more connected to politics than anything else. So crime as in of itself isn't really a hard, measurable statistic that we can relate to any true metrics of health or safety.
Right. Okay. Thanks for that. That's a great thing to remember. I'm going to chat a question from Estelle about Oregon. And she's asking, could treatment, the focus on treatment, be a cloak for further criminalization? And Tisha, maybe if you read the question in the chat, you can speak to that. She's saying if someone gets found with a certain amount of drugs in their possession, don't they get fined, or are they forced into treatment? And then what happens if they don't comply? And then can they end up in jail?
Okay, good question. So yes, Oregon does impose a $100 fine. So it's a citation similar to a traffic ticket for drug possession. But a person can avoid the fine by doing a screening. So if they contact the screening line, that's a way for the fine to be basically avoided. So you don't have to pay the fine. There's no mandate to participate in treatment in Oregon. And there's some very strong language in the measure that says failure to pay a fine can't be a basis for further criminalization, because we do know that the system could adjust and the same people will continue to be criminalized. So so there's no mandated treatment. There's an incentive to do a screening to avoid the fine, but that's not mandatory. So someone can pay the fine and that's it, or they can choose to avoid paying a fine by connecting with a screening, and it's a telephonic screening currently.
Great. Tasha, can you talk about your strategy in California in terms of working on the treatment infrastructure, which you talked about today, but also pursuing, well, I don't know if it's a ballot initiative or what the vehicle would be, but actually a decriminalization measure? Are those two things happening in parallel? Does one come first? What are you thinking about that?
Well, we're trying to think of there are multiple layers to planning for a potential ballot measure in 2024, for example. We're thinking of a legislative strategy where, to the extent that there are service gaps, how can we get the legislature to prioritize funding for those services? So how can we build the infrastructure and lay the groundwork so that if we do decriminalize in California, people can access services immediately, from day one. So in the interim, we're trying to meet with members of various coalitions in every sector imaginable, try and think through what's the best policy for California? What is the best model? Because what works for Oregon is not necessarily going to work for California. So what can we do? And so I think a lot of participants in this webinar would absolutely love to have a conversation just about how should we build our system, and what are the steps to getting there. So those conversations are underway. Legislatively, I mentioned the screening line where we're trying to use, the California budget process to get funding to expand a line, like a screening line for substance use disorder. So somebody can access, a referral and connections to services that way. And then, just in terms of, I mentioned, what are the revenue sources? How are we going to fund this new system? So one component is clearly diverting cost savings from the existing system. So cost savings from arrests and prosecution and incarceration. How can we use that money and invest it in alternatives that are going to be more meaningful and centered in health and well-being? But other than that, how can we fund these services? Because anytime you go to the legislature, you try a ballot measure, if it's a huge fiscal impact, it gives them pause and they're concerned about, oh no, we're going to fund a whole new bureaucracy and I don't want to do that. So how are we going to do that? How are we going to fund it? Would love feedback on how can we go about doing this. There's opioid settlements, from the litigation that's going on. That could be one way you can access those funds to expand services. And that's what in Oregon, in fact, some of the settlement money has gone directly into funding services for the decriminalization measure. So that's kind of what's underway in California, but it's a longer view. It's a bigger state. We have, it's very nuanced in terms of what the approach should be. And so that's kind of where we are right now.
So the idea of a ballot measure in 2024, that's on the table, not necessarily 100% of a decision to go for that, but something that's under.
Well, yeah, I would say it's under serious consideration. It's it's an aspirational goal, but I think there's a lot of legwork that needs to happen between now and then. And the reason why it's 2024, not 22, is because of all those reasons I mentioned. There's just a lot of due diligence that needs to happen now. And we think in the state, it's going to take a few years. So I'd say 2024 is what the goal is. And we're working towards it, but it's, yeah, we'll see. I mean, the legislature may step in and do something before then, which would be preferable, but I'm not sure if legislatively, if there's an appetite. But the voters are with us, on the side of decriminalization.
Okay, well, that's a great segue, because now we're talking about next steps. And I think everyone can see that we really want to be involved in this conversation that Tessia has been talking about. And it's something that at California Bridge, we're really committed to doing for the long haul. I do want to tell people, if you didn't get your question answered, please know that this is not the end of this conversation. We're going to have more webinars, blog posts, and other communications on this topic. You should just make sure that you're signed up on our listserv to get our updates. And also, we're really happy to get questions and comments on this topic or any topic to our email info@californiabridge.org. So for final words, I'm going to turn it over to Dr. Amy Mullen, who is an emergency physician at UC Davis. She's also one of the founders of California Bridge and is very passionate about this topic. And she is going to talk to us about next steps.
Thank you, everyone. And I also wanted to thank our wonderful, inspiring, thought-provoking speakers. Thank you so much for your time and your expertise. We really would not be here without you. I don't know about everyone on this, but I've undergone a little bit of an evolution over the past couple years, thinking about people who use drugs and frequently talking about the system of care that we have, and coming to the realization that the system of care that we have for people with substance use disorders is jail. And to realize how that is a huge driver of the harms that our patients are experiencing. We do not put people with COPD or lung disease who continue to smoke in jail. And so really what I have come to realize is that what we're currently doing is wrong. And no matter where you are in thinking about this as a problem, I think we can all recognize that our current system has failed. And so what I encourage you to do from here is to continue to learn, to grow, and to challenge your assumptions. But I also hope that you leave here inspired like I am. And at California Bridge, we have really realized that we can no longer sit on the sidelines, that really we need to use our voice, particularly as medical providers, to speak out against a system that is functionally unjust. So please go on to the next slide. And I am hoping that all of you will join us. And so what we are doing at California Bridge is creating our own advocacy fund. And I'm hoping that you leave here inspired to use your voice, to join us, to speak out for our patients and really work towards a system that is equitable, just, and is really focused on treatment. So on the next slide, what I'm going to show to you is our advocacy fund. And I hope that you will join us in this movement. We have a nice fancy QR code. If you want to hold your phone up, it will take you to our link. And so I just want, in closing, I want to thank you so much, because everyone on this call has been so important to our movement. And I really appreciate your time and attention, and hope that you will continue this conversation. And for those that you are energized, join us and use your voice to help make a positive change for our patients. Thank you so much.
Great, thanks, Amy. And I really want to thank everyone for joining us. It was amazing. This was a great attendance. We're so happy to have you all here. So please join us. As I mentioned before, our work on this issue is not supported by our public and private foundation funders. I want to be very clear about that. And that's why we are raising money to organize ourselves and all of you to be active on this issue. So all contributions are appreciated, and stay tuned for more information from us about this issue.